Let's get to trauma of the brain, okay, or brain trauma. So, brain trauma. So, very important thing is the intracranial pressure, okay? That's like crucial, and this is in general. It's not only about brain trauma, but it's also about strokes and whatever, okay? So now we're talking, watch out, there's a difference, of course. Brain trauma means you hit your head and you have a brain trauma. Stroke means what? Well, means what? Stroke means either one of the vessels is blocked, okay, so it's normal infarction, or it ruptures, okay, yeah. That's special for brain. The rupture cause, it's not as common, 20% only, but anyway, those are some kind of spontaneous bleeds, we could say, okay, compared to trauma, okay, yeah. But anyways, in both cases, and in any case, it's not only bleeding, but also brain tumors or infections, abscesses, whatever. Everything at the end like leads to increased intracranial pressure, and that's what you are as a neurosurgeon dealing with. And this is the ultimate thing you can do to maybe save the patient, okay? It's very mechanistic, but it's like that. It's the intracranial pressure which causes the buzz in the brain, the problem, okay? Because the brain is locked in the skull. I mean, liver is fine, it can expand a lot, but not the brain, okay? So, it's intracranial pressure, but you know the equations because the main thing is the cerebral perfusion pressure. So how do you count the cerebral perfusion pressure? Does anybody remember? CPP. So that's the pressure when the blood flows there, okay? Yeah. And of course, if there is occlusion, behind this occlusion, there's 0 of CPP, yeah? Yeah, get it? If, as we talked about the ischemic stroke, there's 0 of CPP. So now in general, CPP, how would you count it? I think this is the only important formula in neurosurgery, I guess. So how would you count it? If you remember, there's MAP, okay, minus this dreaded intracranial pressure, okay? So there are 3 factors. MAP is done by what? By heart, of course, yeah. How do you count MAP, again? Yeah, but I don't know how you get the parameter of the total resistance. So I guess some mathematician went and figured out the formula, but it's useless for me now, because much simpler is what? What is it? You got the systolic pressure plus 2 diastolics divided by 3. And why there is double times the diastolic pressure? Because it's longer. You're longer in the diastole. So basically it should be, you got a systolic pressure, diastolic pressure, and it's a bit lower, okay? So that's simple, I'm a simple man, so I need simple numbers. So this is the classical thing. I'm sure this is a great definition, but won't help me next to the patient, okay? Because I don't know what his resistance is. Maybe I can easily count cardiac output. Anyways, what is the MAP? I mean, what are the normal numbers? What are the normal numbers of MAP? Well, 70 to 100. Yeah, well, it's 70, some say to 105 millimeters of mercury. Okay, what is the normal ICP? That's very important. And how do you measure ICP, by the way? How would you measure it? And it's invasive mainly. Of course, maybe you can have, again, some algorithms, but how would you measure ICP, guys? That could be it, sort of, but it's much easier to drill a bar hole here and put a pressure sensor, okay? Because the ICP is the pressure of the tissue out of the vessels, get it? So if you have edema, this increases, okay? They really drill a hole, they cut the skin, and then they do a bar hole, which stays there, you're gonna have a hole over there, and they put a pressure sensor. And guess why you keep the sensor there, why it is useful? When would you use this, like, when you would leave the pressure there longer? Because of course you can tell from what you can tell that the pressure inside the brain increases by what? Non-invasively. Because this is, you just check the CT or MRI and you see if the brain is like, if you see gyrifications, so there's space. But once the brain it changes colors, and suddenly when you lose the gyrification, you know that there's edema, brain edema, and that the ICP goes up. There are options typically. After brain trauma or surgery, you do a CT after several hours and you check it out. And then you have to check it out again. So you scan the patient all the time. So that's one way. You can scan them all the time, but if if it's a serious brain trauma, you would have to scan them many times. What you're going to do, you're going to place a sensor there and you don't have to scan them all the time, okay? Also, and that's what you reminded me, also, for example, guess when also the intracranial pressure really increases, and it could be very fast. And it's with bleeding, but you have to bleed somewhere. Where do you think? And they can fall into coma very fast. Oh, okay, yeah, you're right, yeah. And so in general, you're bleeding into? Okay, or intracranial space, that's very general. Into the ventricles, okay, or in case of this one, that would be below into basal cistern, so into the liquor, okay, into the cerebrospinal fluid, and the blood can block the way out, and so suddenly you have hydrocephalus, okay, acute hydrocephalus. And in this case, how would you cure this? So during any bleeding in the brain, this can happen. And what you're going to do? In this case, you have to drain it. So actually, they use the same bar hole because you're placing always somewhere over here in front, right side, because we know it's like, let's say, this ideal spot for putting things over there because we think that you won't damage so many things. And it's a silicone hose, small hose that you put inside. You put it there with a wire, then you take it out, and suddenly, and if there's a high pressure of the liquors, suddenly the liquor gets out. And with this, you can also very easily, you can put the hose like this, and then you know exactly by the level of that, what is the pressure inside, okay? Very mechanistically, again. So either you can put a sensor, or if there is a bleeding and you need to leave it there, because there's decreased drainage of the cerebrospinal fluid, you put a normal plumbing over there, okay? Yeah? And of course, this immediately helps the patient when you drain the blood and with the accumulated liquor over there, yeah? So, but ICP, so a normal pressure of ICP, so what would we expect? What is the normal pressure? It has to be very low, so it's 5 till 15 millimeters of mercury, okay, yeah? When this goes over, and remember, limit is like 25 or 20 sometimes, depends. But when this goes up, you're having hypertension, intracranial hypertension. So basically, you as a neurosurgeon, you want to keep the ICP below 20. And now it depends what's the cause, if it's brain edema, whatever, and when this goes up, then you're having a problem because the CPP decreases, yeah? The perfusion pressure. So what's the normal CPP? It should be around 70, depends what part of the brain, also 60 to 80 millimeters of mercury. So when ICP goes up, it's a problem, and that means also, in other words, that CPP is going to go down. Okay, and why? Because I'm having a vessel over here, that there's a pressure, that's artery, there's some kind of map, okay? And so there's some kind of CPP then. And now I'm having pressure from outside, so this collapses it's fighting the pressure within the vessel, fights the pressure from outside. And if I'm having something over that presses it, it compresses the pressure. Of course, when the ICP goes up due to some edema or whatever, there's a reflex. So basically the body or the brain wants to fight its decreased perfusion because the CPP then goes down. So it increases what? MAP, of course. So it's like, of course, the values are not stable, but MAP goes up, okay? So it fights, it tries to increase the CPP, and again, the pressure, but you're pushing more blood into the brain, so again, the ICP increases, okay? And this leads to a special reflex, by the way. And you know what you call the reflex? Exactly, Cushing's reflex, remember. So, because we talked about Cushing many times, remember, last year? And Harvey Cushing was a neurosurgeon, so this is more like within his field, not only the endocrinology thing, but typically Cushing reaction, how does it look like? Very good. That's very important. The pressure goes up, so blood pressure goes up, and also irregular breath. And remember, unfortunately, when someone has Cushing's reflex, it's very likely he's like, you're losing him. Okay? So it's a sort of a death sentence in a way. So watch out, Cushing. You don't want to have Cushing's reflex. You don't want to have Cushing's disease as well, but Cushing's reflex is more ultimate, I would say. So irregular breaths, also that means there's a problem with the brainstem, very likely that the ICP is really high. Okay? And what you're going to do in all cases, there are some moves you can do. Again, it depends if it's a brain edema. You can give some solutions to like mannitol, for example. Now, again, it depends what is the cause, why the pressure goes up. Also, you can change the position of a patient, so you put the head bit up, okay? Sometimes you use the hyperventilation, remember, and it helps a bit. But anyways, the only ultimate thing how you can help them is what? So when I don't know what to do, there's brain edema due to trauma or stroke or whatever, or there's inflammation, and the pressure within the skull increases. So the only thing I can try to save them, and is going to really work to decrease ICP is? Yeah, well, you take out the bones, okay? And basically now it depends. Again, what side? If there is one hemisphere more swollen, then you do a one-sided craniectomy. Or if there is an edema and you see on a CT that the gyrification disappears from both sides, you take both parietal bones and so basically the patient would look like, or wait a sec, you call this bilateral craniectomy. So if this is, well, yeah, well, I should leave the brain there maybe. So this is like from frontal view. Yeah, like a nose, eyes, and you have to leave this piece. So you take this piece out and this piece out. That's the bilateral craniectomy. And why are you leaving the middle part over there? What do you think? And I said it maybe last year already, but yeah, the silence of the lambs in one part. Remember that? You saw that he's like eating, he opens his brain. Anthony Hopkins opens the brain like a pot, or what do you call the cover, for if you have a meal and you put it, what do you call that? It's a lid, like a lid. So he opens the brain like a lid, which is and the person still talks. Okay, and then he, takes this piece of the brain and, puts it on a pan, and he's supposed to eat it, yeah? Okay, so that's a big mistake, because you cannot do that. You will kill him. So you have to leave this strip of bone over here, and the reason exactly is because you got a sinus over there. And if you destroy the sinus, the brain dies. Okay, so always there has to be this 3 centimeter slip of skull left in the middle, yeah? So this part has to be there. Okay, so bilateral craniectomy, and use that every time you don't know what to do and the person is dying, okay? Fine. So this was a comment for ICP. Please, crucial thing, parameter that neurosurgeons need and that they're monitoring, okay? Fine. So, and now let's get to the brain trauma. So, thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.